Welcome to Board Pearls. This is episode 3 of 5 of the GI Infections chapter in the Special Populations and Acute or Supportive Care module. In this episode, we cover the community-acquired bacterial diarrheas, travelers, diarrhea chosen by region with empiric azithromycin or rifaximin, the bacterial enterocolitis pathogens including the no antibiotics for EHEC rule because of hemolytic uremic syndrome risk, and the foodborne toxin syndromes recognized by the time to onset. The community-acquired diarrhea separate cleanly once you stop grouping by symptoms and start grouping by acquisition pattern. A patient with 3 days of diarrhea is not a diagnostic puzzle. The puzzle is the exposure history and what it predicts about the pathogen, and the pathogen predicts the treatment. Start with travelers. Diarrhea. 30 to 50% of travelers from high-income to low- and middle-income regions develop diarrhea. Bacterial pathogens cause about 80% of cases. Enterotoxigenic and enteroaggregative E. coli together account for more than half worldwide, and the invasive species vary by region. Region matters because the empiric antibiotic depends on which invasive pathogen dominates and what its resistance pattern is. Campylobacter dominates in Southeast Asia. Shigella dominates in South Asia and Africa. Nontyphoidal Salmonella circulates throughout. Fluoroquinolone resistance in Campylobacter has spread so widely that azithromycin is now the preferred empiric agent in Southeast Asia and is moving into that role elsewhere for the same reason. The empiric choice, then, is azithromycin 1 gram as a single oral dose, or 500 milligrams daily for 3 days, in Southeast Asia and increasingly in other regions. Ciprofloxacin 500 milligrams twice daily for 1 to 3 days remains acceptable in regions without high fluoroquinolone resistance, which is now a shrinking list. Rifaximin sits in a narrower indication for a mechanical reason. Rifaximin is essentially non-absorbed. It acts only in the gut lumen. That works for non-invasive E. coli, which stays in the lumen, but invasive Salmonella, Shigella, and Campylobacter reach the lamina propria, where systemic drug is required. The absorption profile predicts the indication. Rifaximin, 200 milligrams 3 times daily for 3 days, is approved only for afebrile, non-bloody travelers, diarrhea in adults, and giving it for a febrile or dysenteric illness is treating the wrong compartment. Loperamide added to antibiotics in afebrile, non-bloody disease shortens illness by 1 to 2 days. The pairing changes when Shiga toxin-producing E. coli enters the differential. Slowing transit prolongs Shiga toxin exposure and increases hemolytic uremic syndrome risk, so loperamide is off the table whenever the stool is bloody or the exposure suggests an enterohemorrhagic strain. That brings the no antibiotics for EHEC rule into focus, because it is the most tested decision in this chapter. The classic stem is bloody diarrhea after undercooked hamburger or contact with cattle, or a child returning from a petting zoo with bloody stools and severe abdominal cramping but minimal fever. Antibiotics in Shiga toxin-producing E. coli lyse the bacterium and release additional Shiga toxin into the gut. Loperamide slows transit and prolongs toxin exposure. Both interventions increase the risk that Shiga toxin reaches the bloodstream and damages renal endothelium. The right answer is intravenous hydration and renal monitoring alone. Hemolytic uremic syndrome is the leading cause of acute kidney failure in children, and it follows Shiga toxin-producing E. coli and Shigella dysentery. The recognition cue is severe abdominal pain with bloody diarrhea in the absence of fever, often with imaging that mimics ischemic colitis. Hold antibiotics. Hold loperamide. Hydrate. Watch the platelet count, the hemoglobin, and the creatinine. Move to the rest of the bacterial enterocolitis differential, because each pathogen has its own treatment rule, and the rules look contradictory until you see what drives them. Campylobacter is the leading cause of acute bacterial diarrhea in the United States. The exposures are poultry and direct animal contact, including the rescue puppy stem. Incubation is about 3 days. The illness can begin with fever and malaise before diarrhea appears, and diarrhea can progress from watery to bloody. Campylobacter occasionally mimics appendicitis with right lower quadrant pain from terminal ileitis. Antibiotic indications are high fever, bloody stools, bacteremia, or risk for complications such as older age, cirrhosis, pregnancy, or immunocompromise. Azithromycin 500 milligrams daily for 3 days is the drug of choice, and fluoroquinolones are losing ground globally. Post-infectious complications include Guillain-Barré syndrome, hemolytic uremic syndrome, reactive arthritis, and post-infectious irritable bowel syndrome. Nontyphoidal Salmonella sits at a different rule. Antibiotics in immunocompetent gastroenteritis do not shorten illness and prolong fecal carriage. The exception list is what the boards test. Antibiotics are given for severe disease, age extremes, immunocompromise, sickle cell disease, prosthetic vascular grafts, bacteremia, or typhoid fever. The unifying principle is extraintestinal seeding risk, not GI symptom severity. Sickle cell disease predisposes to Salmonella osteomyelitis through the encapsulated organism's tropism for infarcted bone. Prosthetic vascular grafts are seeded by transient bacteremia and become mycotic aneurysms. Immunocompromise blocks intracellular Salmonella killing. The threshold for antibiotics is therefore set by where the pathogen might go, not by how bad the stool looks. The chronic carrier state is rare but increases with cholelithiasis because Salmonella forms biofilms on cholesterol stones in the biliary tree. Shigella runs in the opposite direction. The infectious dose is 10 to 100 organisms, which is low enough that reducing fecal shedding has outsized public health value. Shigella does not establish a chronic colonic carrier state, so antibiotic-induced shifts do not produce the prolonged shedding that drives the no antibiotics rule in nontyphoidal salmonella. Treat most cases with a fluoroquinolone or azithromycin. The clinical pattern is biphasic, starting with watery diarrhea from Shiga toxin and progressing to bloody dysentery as the organism invades mucosa. Antiperistaltic agents are avoided because they prolong illness. Yersinia enterocolytica is the Crohn's disease mimic. The classic stem is fever, right lower quadrant pain, and prolonged diarrhea after undercooked pork, with imaging showing terminal ileitis and bulky mesenteric adenopathy. Pharyngitis can accompany the diarrhea. Reactive arthritis and erythema nodosum often follow. Uncomplicated cases self-resolve. Antibiotics are reserved for bacteremia, extraintestinal disease, or special hosts. The unifying high-risk feature is iron-replete state, because Yersinia uses iron as a virulence cofactor through the Yersinia-Bactin siderophore system. Cirrhosis with elevated transferrin saturation, hereditary hemochromatosis, and transfusion-dependent states all push Yersinia from contained gut infection into bacteremic disease. Doxycycline, trimethoprim sulfamethoxazole, and fluoroquinolones reach intracellular Yersinia and are preferred over aminoglycosides for tissue infection. Vibrio vulnificus runs on the same iron logic. Raw oyster exposure or seawater wound contact in a cirrhotic patient is the classic stem, and the presentation is severe sepsis with necrotizing fasciitis. Treatment is doxycycline plus a third-generation cephalosporin. Doxycycline reaches intracellular Vibrio and macrophages, and the cephalosporin covers extracellular bacteremia. Monotherapy fails in the high-mortality necrotizing fasciitis presentation, which is why the combination is the answer. Listeria monocytogenes is the gram-positive intracellular bacillus that grows at refrigeration temperatures, which is why the food vehicles are soft cheeses, unpasteurized dairy, deli meats, refrigerated smoked seafood, and raw produce. In immunocompetent adults, Listeria produces a self-limited febrile gastroenteritis. The high-yield populations are pregnant women, neonates, older adults, and immunocompromised hosts because Listeria is intracellular and requires CD8 T-cell-mediated containment that these populations lack. In pregnancy, maternal flu-like illness can mask placental seeding with chorioamnionitis, fetal demise, preterm delivery, or neonatal sepsis. Treatment is intravenous ampicillin, with gentamicin added for severe disease or meningitis. Cephalosporins do not cover Listeria, which is why empiric meningitis regimens add ampicillin in patients over 50 or in pregnancy. Trimethoprim sulfamethoxazole is the penicillin allergic alternative. The foodborne toxin syndromes belong in this chapter as a recognition pattern, not as a list. They share rapid onset within hours of ingestion, absence of fever, and resolution within 24 to 36 hours. The mechanism is preformed or rapidly elaborated toxin rather than mucosal infection, and the clinical implication is that stool cultures and antibiotics are unnecessary. The diagnostic anchor is the food history and the time to onset. Staphylococcus aureus enterotoxin produces explosive vomiting 1 to 6 hours after ingestion of custards, cream pastries, mayonnaise-based salads, or cured meats left at room temperature. The toxin is heat stable, so reheating does not destroy it. Bacillus cereus splits into two syndromes from two toxins. The emetic syndrome is the reheated fried rice stem with preformed cerealide and vomiting at 1 to 6 hours. The diarrheal syndrome is meats and sauces at 8 to 16 hours from enterotoxin produced after ingestion. Clostridium perfringens type A is the warm-held meat or gravy stem with watery diarrhea at 8 to 16 hours. 2 seafood syndromes round out the recognition set. Ciguatera follows ingestion of large reef fish, such as barracuda, grouper, snapper, or amberjack, that have bioaccumulated ciguatoxin from dinoflagellates. The toxin activates sodium channels and produces the pathognomonic cold allodynia, where cold objects feel burning hot, along with perioral and extremity paresthesias, bradycardia, and hypotension. Scombroid is histamine fish poisoning from inadequately refrigerated tuna, mackerel, or mahi-mahi. Bacterial histidine decarboxylase converts fish histidine to histamine, and the presentation within an hour is flushing, headache, urticaria, peppery taste, and palpitations. Treatment is antihistamines, and rapid resolution distinguishes it from true seafood allergy. Pull the bacterial and toxin half together. Acquisition pattern is the organizing principle. Travelers, diarrhea selects the empiric antibiotic by region and resistance, with azithromycin moving into Southeast Asia and increasingly elsewhere because of Campylobacter fluoroquinolone resistance, while rifaximin stays in the narrow, non-invasive E. coli role because the drug is non-absorbed. Shiga toxin-producing E. coli flips the rule entirely because antibiotics release more toxin and loperamide prolongs exposure, and the right answer is supportive care with renal monitoring. Nontyphoidal Salmonella holds antibiotics back unless extraintestinal seeding risk is on the table, while Shigella treats nearly every case because the low infectious dose makes shedding the public health issue. Yersinia and Vibrio run on iron biology, Listeria on intracellular immunity, and the foodborne toxin syndromes on the time to onset that tells you cultures and antibiotics are unnecessary. The next episode takes the parasitic and viral diarrheas, where exposure history drives the parasite differential from Giardia to Entamoeba histolytica to the pre-steroid strongyloides screen, and norovirus leads the viral gastroenteritis differential on its outbreak pattern. For the full chapter, the practice vignettes, and the topic tag question bank, head to boardpearls.com. You'll find the rest of the series on Apple Podcasts, Spotify, or wherever you listen to podcasts. That brings us to the end of episode 3 of 5 of chapter 33, and I'll see you in the next one.